Hello everyone. Yes, myself Dr. Sanjay Khatri. I am here to give a recall on UPSC 2022 Pediatrics question. Yes, hope you have given your exam with a good number of questions you are able to solve it. So yeah, it's a recall question discussion what we have faced in the Sunday exam. Now see, little bit introduction about Unacademy. Now see, this is Unacademy and Prep Ladder with Unacademy, or Unacademy and Prep Ladder with Prep Ladder. So you have iconic subscription. You have iconic subscription. Yes, Unacademy unlock from 17th to 22nd, 20% off. Mission INI-CET 2022 high yield revision batch. You feel the difference. It starts from 21st July. Batch duration 360 hours, 4 hours a day. The top educator with the high yield discussion. Yes, we understand what INI-CET means to you. So join Unacademy for this batch. Yes, FMG 2022 batch. Congratulations, Dr. Jad. Yes, you may be one of them in next time. So it says NEET PG 2023 test and discussion batch for repeaters. Suppose you have done with some other platform, it's the time for you. Join Unacademy and feel the difference. It's a 6-month course. The module 1 test and discussion and high yield theory. 2 modules designed by top brain in the Unacademy as per your need. This is the subscription which you can take in Unacademy, either plus, iconic, light, in which you are eligible to do all type of tests, final prof, and UPSC CMS subscription. Don't forget to use code Dr. Sanjay Live to get additional discount. After that brief introduction, actually, can we call it recall? Because paper is in our front. Like it's not like FMG or NEET PG, because we memory based question. But now here questions are straight. With us, we find to know the clear answer, and the person who are preparing for UPSC next time, see how type of questions, what type of questions is there. The UPSC pediatrics question mainly from neonatology, growth and development, immunization, poisoning. No systemic pediatrics is there. No question in hematology, nephrology, cardiology. No systemic, but high yield developmental milestone. Questions about vaccines. Questions about various programs is there in UPSC. So yeah, I will cover few of them in this sessions and give you orientation how this paper and how upcoming paper will be if you are planning to give next year. Now, this is the first question. Good evening, everybody. Good evening. Now, identification of 4D is a key element of which national health program? Simplest of the question. 4D. Yes, you all have done right. That this is RBSK program. RBSK program. Rashtriya Bal Swasthya Karyakram. RBSK. What are 4Ds in RBSK? Defect at birth. That may be neural tube defect, that may be cleft foot, that may be cleft palate. All are covered in RBSK. Disease of childhood, rheumatic fever, tuberculosis, skin diseases, scurvy, all these are covered in disease of childhood. Then deficiency, rickets, scurvy, vitamin A deficiency, then developmental delay. All type of motor developmental delay, autistic childs are covered in these. These are the 4 Ds which is covered in RBSK. Now, previous UPSC exam have a question. All are included. All diseases are included in RBSK program except. So, grossly you remember 4D and individually defect at birth. That may be neural tube defect, Down syndrome, cleft lip and palate, dysplasia of hip, congenital cataract, deafness, CHD, all type of CHD, VSD, ASD, TOF, coarctation, PDA, TGA, TAPVC, all are included in RBSK. That is the defect at birth and retinopathy of prematurity. So you should know these are the defect at birth included in RBSK. Then diseases of childhood, rheumatic heart disease, skin diseases, reactive airway diseases, convulsive seizure disorder included in RBSK, deficiency, anemia, vitamin A, vitamin D, severe malnutrition, goiter, all are included in RBSK program. And developmental delay, just see autistic child, learning disorder, ADHD, all are included. So previous 2 year questions are coming, what are not included in RBSK. So maybe not included nephrotic syndrome, not included, like that. You need to remember these diseases included, but this year they make it more simpler. They make it more simpler. 4Ds in RBSK. 4Ds in RBSK program. These 4Ds are defect at birth, diseases of childhood, deficiencies, and developmental delay. So it's my request, check the pattern of UPSC. If you are preparing for UPSC, so just remember these 4D very well, because 21 and 20, these questions are there. All diseases included in RBSK except. So you should remember about these 4Ds. Now answer this question. What you have written? Yes, Vikram. Yes, Shiny. What you have answering in this? Which vaccines is stored in top rank of main refrigerator compartment at temperature of 4 to 10 degrees centigrade? 10 degrees centigrade. Definitely, if we have a freezer, this is the freezer, fridge with the doors. This is the freezer compartment. This is first compartment. This is second compartment. First, second, and third. And this is deep freezer. This is deep freezer. Now, door. No vaccine should be kept at door. So that is out. No vaccine should be kept at door. So what we kept in the deep freeze? That is OPV. And what at the first rank? BCG, MMR, and measles. At first rank. Second, all other vaccines. And third, we put diluent. So that they want to know from you, what are the vaccine you kept at first rank? DPT? No. DPT? No. Typhoid? No. BCG, measles, MMR. Answer is D. BCG, measles, MMR. Answer is D. This is the diagram. This is freezer. So we keep OPV vials here. First rank, top, we keep BCG, measles, and MMR. Diluent at the base. Diluent at the base. And rest to middle for all other vaccines. The MCQ which they ask so many times in UPSC and NEET PG also, which vaccine you can't deep fridge, which vaccine you can't put in deep freeze. So all vaccines in which spelling T letter comes, whether it's a DPT, hepatitis, typhoid, T is there, should not be deep freezed. We can keep BCG, measles, and MMR into deep freezer. We can keep, but all T containing vaccines should not be deep freeze. Why? Because if you put DPT in the freezer and then you use that DPT, aluminum hydroxide adjuvant is destroyed, then that DPT causes sterile abscess. So do not deep freeze these vaccines. Deep freeze OPV, first rank BCG, measles, MMR. Am I clear? Am I clear? BCG, measles, MMR in first rank of refrigerator. Answer this question. Autism, ADHD, is one of the favorite topic, one of the favorite questions in UPSC exam. So autism spectrum disorder characterized by which of the following? Onset before 3 years of age. Yes, generally suspicions before 3 years of age. Impaired verbal and gestural communications. They are poor in verbal communication. Remain shy. Social contact is minimal. Yes, this is a feature. Stereotype, restrictive behavior. They have a very less social contact. Very restrictive child. Yes, this is also a feature. Tangential speech is not a feature of autism. Tangential speech, person continuously speaking without knowledge what he is speaking. What it's a feature of overactive child. Sometime some part of the brain involvement is there, but it's not a feature of autism. Child speak verbally continuously with irrelevant. It's topic not some. Suppose teacher asks, tell me something about month in a years, and child start speaking something about the seasons, winter, summer, something else. What they supposed to talk something else, but continuously talking. That is tangential speech. So this is not a feature of autism. 1, 2, 3. It's a feature of autism. So answer is A. 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 Yes, Dr. CP is right. It's A. Dubey, it's 1, 3, and 4. No, no, no. Tangential speech is not a feature of autistic child. Autistic child is a dull, who very less speech is there. How can he speak continuously? Some varied speech is there. That is not a feature of autism. 1, 2, and 3 classical. 1, 2, and 3 classical feature of autistic child. Answer this question. Yes, I expect this answer from you. A 7-year-old child brought to the emergency with seizures and drowsiness. Child has been receiving some drugs for fever for past 2 days. Past 2 days. Child found to be cyanosed with oxygen saturation of 40%. Unresponsive to oxygen therapy. Blood gas revealed normal PO2. Normal PO2. Here is the crux of the question. SpO2 low. PaO2 normal. It indicate that you are dealing with a case of methemoglobinemia. Methemoglobinemia. So what is methemoglobinemia? The key point in this question, saturation low but PO2 normal. When somebody asks you, tell me the causes of cyanosis, and you can say cyanotic CHD, lung disease, liver disease, and fourth, abnormal hemoglobin. That is methemoglobin. Now see here, this is hemoglobin. If it convert into methemoglobin, the condition known as methemoglobinemia. In hemoglobin, iron is in ferrous form. In methemoglobin, iron is in ferric form. Now see, why hemoglobin normally not convert into methemoglobin? Because there is an enzyme known as cytochrome B5 reductase. Cytochrome B5 reductase. If this enzyme is not there, cytochrome B5 reductase is not there, so hemoglobin will convert into methemoglobin, and condition known as methemoglobinemia. So what happened? What happened if hemoglobin convert into methemoglobin? See, if methemoglobin level is absolute level more than 1.5 gram %, or you can say more than 10% of total hemoglobin. Suppose hemoglobin is 15. If methemoglobin is 1.5 gram %, 10% of total hemoglobin, cyanosis appear in the body. Cyanosis appear in the body. So this is methemoglobinemia is due to deficiency of cytochrome B5 reductase. Cytochrome B5 reductase, that is congenital methemoglobinemia. This enzyme is not there in RBC. If level is more than 1.5 gram %, cyanosis appear. Cyanosis appear. Now, acquired methemoglobinemia, there are some drugs which causes inhibition of this enzyme, leads to acquired methemoglobinemia. Antibiotic, trimethoprim, sulfonamides, dapsone. Remember dapsone. Anti-malarial, chloroquine, primaquine. You remember these drugs: chloroquine, primaquine, trimethoprim, sulfonamide, dapsone. Now see, local anesthetics, mainly benzocaine and lignocaine, leads to methemoglobinemia. Aniline dye present in a toothpaste. If sometime child comes with eating so much toothpaste, or a particular place water contain more level of aniline dye in their blood, methemoglobin increase, so they become cyanosed. Their saturation will be 80%. And other metclopramide, resburicase, chlorate, bromate, nitrate, these are present in the soil, in the water. So always remember this. UPSC have a traditional type of questions. Drugs causes methemoglobinemia. Drugs causes G6PD deficiency. Drugs contraindicated in a baby who mother is taking those drugs, contraindicated in breastfeeding. So these are the prototype question asked in UPSC for so many years. This year they ask about G6PD and methemoglobinemia. Now come to the question. Which drug you find in this question which leads to methemoglobinemia? Now you got it. Answer is chloroquine. Patient is taking chloroquine for fever. Chilson's-Riger fever, patient start chloroquine. And that chloroquine, if high dose taken, leads to methemoglobinemia. Now, how it's happened? See, if percent of methemoglobin below 15%, generally no symptoms. But if methemoglobin is 15 to 70% of total hemoglobin, child appears cyanosed. 50% of total hemoglobin, child is confusion, syncope. More than 50%, seizures, coma. You mean to understand? Suppose total hemoglobin is 15. If methemoglobin is more than 8, more than 50%, child comes with seizures, coma, like in our patient. Cyanosed, brought to an emergency, seizures, drowsiness, definitely methemoglobin is more than 50% of total hemoglobin. So, which drug? Chloroquine. Examiner given a very nice hint here. Saturation low, SpO2 low, PO2 normal. My friend, this is the classical thing to diagnose methemoglobinemia. This is the classical thing. See, your pulse oximeter showing saturation 80%, but your blood gas shows PO2 121. Cyanosis, low SpO2 in presence of normal arterial PO2 by ABG. It's confirmed the diagnosis of methemoglobinemia. Methemoglobinemia. So remember, methemoglobinemia, you may find question. Clinical practice, you may find a cyanotic child. Echo normal, CT normal, USG normal, still child is cyanosed. Think about methemoglobinemia. Think about all those drugs child is on. Yes, generally we saw 2 patients every 6 months of methemoglobinemia. Yes, but to know this, you have a high in suspicion. You should know about the condition. Saturation is 80. If everything rule out, do a ABG. If PO2 is normal, it is methemoglobinemia. Can anybody put in the comment box what drug we use in the treatment of methemoglobinemia? Which drug we use in the treatment of methemoglobinemia? Which drug we use? Yes, CP Dubey, yes. Methylene blue, methylene blue. In infant, sometime in neonate, sometime when we have methymoglobinemia, we start vitamin C drop also. So yes, it's a methylene blue we generally give in the treatment of methymoglobinemia. Methylene blue. This is again probably a easiest answer, easiest antidote to reverse muscarinic effect of organophosphate toxicity. I want answer from you. Simplest, yes, B, atropine, 0.05 milligram per kg IV. You can repeat also, but generally book says atropine given in infusion is better than given in IV bolus. So when your diagnosis is sure that child is having organophosphate poisoning, having significant effect, so counteract those effect, give atropine. Last year, I witnessed this question every year since last 3 UPSC exam. If atropine is not given in the choice, then your answer would be glycopyrrolate. And if they ask not muscarinic, they are ask nicotinic effect, then you give palm. So yes, all three these questions are there in previous UPSC exam. UPSC poisoning is a question always. Iron poisoning, paracetamol poisoning, organophosphorus poisoning. You find, just read a chapter from Ghai poisoning and you find definitely 2-3 questions in UPSC exam. That is a smart study. You should know the pattern of the question, and we discuss all these questions in our UPSC section. Okay. Now answer this question. I want answer from your side. I want answer from your side. A 4-year-old child brought with history of ingestion 1 gram of paracetamol to our back. What should be initial management? What should be initial management? If a child comes with paracetamol high dose, you suspect child has taken a very high doses of paracetamol. So yes, the first and foremost effect, give oral N-acetylcysteine, which can be used within 16 hours. Once paracetamol poisoning causes liver damage, then no role of N-acetylcysteine, even it's harmful. So just, examiner is very smart in this question. They ask 2 hour back. So they want to know what you do. No vomiting, no gastric levers, just give oral N-acetylcysteine and it will counteract all the toxicity of paracetamol. Generally, toxicity occur when it is taken more than 200 milligram per kg. Okay, more than 200 milligram per kg. No, Dr. Mishra, in this gastric lavage, because 2 hours back na, so it's always recommended as early as you give oral N-acetylcysteine. It will help to counteract this thing, paracetamol toxicity. Answer this question. I want answer from your side. Urinary alkalinization, enhancing the excretion of which of the following poisoning? Answer. Yes, it's phenobarbital and salicylate poisoning, which is slightly some acidic component. So if you make urine alkaline by giving soda bicarbonate, when urine alkaline, to counteract the pH, these acid rapidly excrete from the urine. So yes, it is given in the book. Phenobarbital and salicylate poisoning, you try to make urine alkaline the urine, it will causes faster excretion of these things, phenobarbital and salicylate, out of the body. Okay, so because it's neutralize effect. If urine is alkaline, it take more acid in the urine, more acid in the urine. So ultimately phenobarbital and salicylates out of the body. So always remember, in these two poisoning, phenobarbital, salicylate poisoning, we try to make urine alkali to increase their excretion for furosemide plus soda bicarbonate. Yeah, we give furosemide and to in more urine output and soda bicarbonate to make urine alkalinized. So these two poisoning you should remember. Very good question. I want answer from your side. What you put answer in this question? What you think? Code given below represent specific type of permanent teeth. Permanent teeth. So Shri is answering B. Okay, let's see. Any other guesses? Any other guesses? If you know nothing now much into deep of dental age, then also you can do this question. You can also do this question. So what they are answering? What they are answering? Close to menarche in girls. So menarche in girls generally 10 to 15 years. If you want to write average, is 12.5 year. 12.5 year. 12 year. So if permanent teeth at 12 year, A choice is out. Permanent central and lateral incisor generally come at 8 and 9 years. So these is out. And molars, they are not specific. Which molar? First molar come at 7 years, second molar come at 13 year. So fourth is also out. Fourth is also out. So when first is out and fourth is out, then what answer is remaining? What answer is remaining? 2 and 3. First and fourth is out. You got it now? I will explain you. Don't worry. I will explain you. Just hold it. Just hold for a minute. This is, I teach you how to approach a question. Menarche age 12 years. Center and lateral incisor 8 and 9 year out. Molar, first molar at 7 year, second molar as 13 year out. First and fourth is out. This is out. First is there. This is out. First is there. This is out. Fourth is there. So what we left with? B choice. 2 and 3. Let's see. Let's see. Central incisor, lateral incisor, molar 1, molar 2, canine. One tooth represent 4 teeth. So these are 20 teeth. 20 teeth. All are primary. So these all 20 teeth erupt by the age of 2.5 years. 2.5 years, 20 teeth, but all are primary. Listen carefully. Listen carefully. 3, 4, 5, 6, 7, 6 year, not a single teeth erupt or exfoliate. So teeth remain 20, but all are primary. But they are asking about secondary teeth. 7 year, first molar erupt. First molar. So teeth become 20. 4 primary, sorry, 20 primary, 4 permanent. 7 year, teeth become 24. Now listen carefully. It is the key. 8, 9, 10, 11, 12. Each year, 4 primary teeth replaced by 4 secondary or permanent teeth. 8 year, 4 central incisor gone and permanent incisor comes. 9 lateral incisor gone, permanent incisor comes. Central and lateral incisor 8 and 9. Now 10 year, first molar gone, permanent premolar. 11 canine goes, permanent canine. 12 molar goes, permanent premolar. So yes, 10, 11, 12. This is probable the age of menarche. At that time, our canine and premolar erupt. Canine and premolar erupt. If you want to choose a single answer is definitely premolar, which come at the age of 12 year. But they answer in a group of 2. So canine and premolar is the best probable answer because they erupt between the age of 10 to 12 years. Make it more simpler. Central and lateral incisor out 8 and 9 years. Molar out because second molar erupt at 13, 14 years out. So what is the best probable to answer? That is canine and premolar. If you want to choose a single which is asked in 2 year back in UPSC, which we discussed in our class also, then it's a premolar. I hope you got it right. Now you understand this. This is the pattern of UPSC which we learn in our batch, in which we discuss the pediatrics. No question from systemic pediatrics. Question on dental age, milestone, typical questions on milestone, vaccinations, programs, neonatology, and all those we have discussed. This question answer is B. Now question from newborn. I hope you all make it right. Answer in the comment box. Answer in the comment box. Yes, lovely. NKN, Shri, Dr. Mishra, Shoaib, Shri Putis, B. Okay. Heart rate is 120 per minute. It's a normal finding. It's not a danger sign. Weight loss 8% within first week of life. Yes. Birth. Every neonate loses weight in first 7 days. And then weight gain start. Birth and 10th day, weight is same. Birth and 10th day, weight is same. Birth and 10th day, weight is same. Okay, birth and 10th day, weight is same. So this is also right. Now, respiratory rate. What is the normal rate in a neonate? Normal rate in a neonate. If it is more than 60, it's a sign of respiratory distress. It is always considered as a danger sign. Yes, temperature 36 to 36.5, it is not considered as a danger sign. If it is below 36, then definite hypothermia is there. Definitely. But yeah, it's very, all programs or guidelines, neonate normal respiratory rate is 40 to 60. When you think something wrong, if respiratory rate is more than 60. So answer is B. B is a danger sign in a newborn baby. Newborn baby. Answer this. Yes, I want answer from your side. This we had discussed in our class. High anion gap metabolic acidosis present in which poisoning? My friend, which poisoning? I told you, just read 4 pages of poisoning and you get 4 questions in UPSC. Answer. Yes, Marvel, Shri, Dubey. What is the answer in this? Shoaib. High anion gap with metabolic acidosis. Metabolic acidosis is classically seen in iron poisoning. Iron poisoning, initial symptoms are GI symptoms. Then 24 to 48 hour, no much symptoms are there. Just GI symptom, intense nausea and vomiting. Then patient presented to you in shock. Severe metabolic acidosis and LV dysfunction. Yes. So metabolic acidosis is hallmark of iron poisoning. And then further, it leads to liver fibrosis and gut fibrosis. Liver and gut fibrosis. So whenever ask you which poisoning having metabolic acidosis, yes, iron should come first in your mind. Iron poisoning. Hepatic fibrosis, last year UPSC question. Hepatic fibrosis, iron poisoning. Metabolic acidosis, iron poisoning. Every year, last 3 years, question on iron poisoning is there. Yes, GI symptoms occur if anybody consume iron 30 to 50 milligram per kg. But lethal dose, these features occur if you consume iron more than 200 milligram per kg. Last year UPSC question was like this. A child presented in the emergency with the empty bottle of a certain drug in which that drug is taken by in mother on regular basis. So which drug somebody taken on regular basis? It may be anti-epileptic, it may be anti-hypertensive, or it may be iron. Mother is taking. This is the association. Pregnant lady in the house taking iron and child is having iron toxicity because they consume so many tablets. Very charming looking tablet. So many tablets they take and toxicity occur. So yes, it is initially GI symptoms, then shock, metabolic acidosis and LV dysfunction. Yeah, this we have not discussed. Yes, we have discussed so many programs in our classes, but home-based care of young child we have not discussed. I want to know whether who make it right. I am waiting for your answer. Home-based care of young child. Which is the answer? Which is the answer? Which is the correct? Correct. Waiting for the answer. It was started in 2014. No, it was started in 2018. Sham is right. Grassroots health worker is Anganwadi worker. No. Grassroots worker is Asha. Asha. Anganwadi to support, Anganwadi worker to support the Asha's work. But Anganwadi is not the grassroots worker in this. Grassroots healthcare worker make 6 home visits. Again wrong. They make 5 home visits. 5 home visits. Infant monitored between 3 to 15 months. 3, 6, 9, 12 and 15. There are total 5 visits. So D is the correct answer. D is the correct answer. D is the correct answer. See here. So this is home-based care of young child. Home-based care of young child. 2018. The purpose of this program, as we see, infant, the most common cause of death, diarrhea and pneumonia. So yes, government laws a very good program, home-based neonatal care, in which Asha visited from natal period, antenatal period till baby is 6 week old, home visit, 6 to 7 home visit. But then they realize to extend it further, problem can occur in infant also. So they introduce home-based young child care. So this started from 3 months of age till 15 months of age. Total 5 visits, in which they train about the feeding practice, weaning practice. They educate them about the importance of vaccination, about the process of proper food, proper hand washing. All these things Asha educate, and Asha is paid 50 rupees for per visit. So total 250 for 5 visit. Yes, this is home based young child care. So start from 9 month to 15 month, total 5 visit. So you can easily rule out it's not started in 2014. Anganwadi is not the main worker, Asha is the main worker. Anganwadi worker is supportive, and not the 6 visit, is the 5 visit. But D is absolutely right. It's work from 3 to 15 months of age. 3 to 15 months of age. So D is absolutely right. Those who have given UPSC and those who are planning to give UPSC, just a different pattern. You need a extra reading for just a month. Extra reading, detail of milestone, detail of immunization, detail of these program with good pediatrics, and you can easily go through first paper, no problem. Now, simplest. Which of the following statement is correct about intradermal fractional inactivated polio? So generally, National Immunization Schedule says birth 6 week, 10 week, 14 week. We give OPV 0 dose, OPV 1 dose, OPV second dose, OPV third dose. National Mission Schedule. Then they feel injectable polio should also included in this. Injectable polio is also included in this. So they are not, they keep the oral polio vaccine, but they introduce 2 doses of injectable polio. One at 6 week, another at 14 week. That is called as fractionated IPV. Why we called it fractionated IPV? IPV, injectable polio vaccine, dose is 0.5 ml given IM. What is fractionated IPV? They make 1/5 of the dose. 1/5 means 0.1 ml, and they given it intradermally. So the previous exam they asked when they give fractionated IPV, 6 week and 14 week. This time they ask what is fractionated IPV? It is 1/5 of the IM dose of IPV. 1/5 of IM dose of IPV. Am I clear? So I feel this question right by everybody. Now. This is something different. Yes, what you make answer here? I want your answer in the comment box. Please try to answer this. According to King's College criteria, when this question comes in exam, I have vivid memory of King's College criteria for liver transplantation in acetaminophen toxicity. Yes, but you could make the answer. If you learn this once, you can make the answer. So according to King's College criteria, acetaminophen toxicity, blood pH should be less than 7.3 after fluid resuscitation, means there is acidosis. Or if there is a plain acidosis, persistent acidosis, or these three, INR should be more than 6.5, creatinine should be more than 3.5, and grade 3 and 4th hepatic encephalopathy. If these three are there, this is the indicator for liver transplant. Yes, damage occur. So choose your question. Acidemia, INR more than 6, creatinine more than 3.4. So yes, 2, 3 and 4. 2, 3 and 4. Answer is D. increase level of SGOT-PT more than 4,000. It's not in the criteria, King's College criteria. It is not. It is not. The main importance to INR and serum creatinine and pH. So remember, if somebody read this criteria, then able to do it very easily. Otherwise, if you are doing this question first time, then you will definitely love to put answer 1, 2 and 3, not the 4. Yes, because it's about liver transplant. Then why we put the kidney dysfunction here? But yes, try to understand kidney dysfunction is a must. The patient may have renal creatinine high. It is one of the criteria when patient goes for renal liver transplant. Yeah, again, simplest of questions which we have discussed in the class so many times. Infant was born 30 weeks of gestation. Weight 1.2 kg. Which of the following is recommended initial feeding? We give IV fluid if infant is born before 28 weeks. We give orogastric feeding between 28 to 32 weeks. We give feeding by spoon and katori from 32 to 34 weeks. And after 34 weeks, we give breastfeeding. Why? Because sucking, swallowing and respiration coordination well established at 34 weeks. So we keep the baby on breastfeed after 34 weeks. So very straight question. 30 week, no confusion. 30 week, orogastric feeding. Orogastric feeding, no confusion. 30 week, orogastric feeding. See here. Before 28 weeks, no proper suckling effort, no propulsive motility of the gut. So we put the child on IV fluid. From 28 to 31 weeks, some suckling breast appears, but still no coordination between sucking, swallowing and respiration. We don't want to take risk. We put the child on orogastric or nasogastric feeding. Then after 32 weeks, some coordination appear. Then we give a spoon and palladi. I will explain you what some coordination. Then why we give spoon feeding. I will explain with the diagram. And after 34 week, definitely we give breastfeeding. Now see, one portion in nose. Here we give the feed. This is nasogastric feeding. One portion in mouth, other is out. This is orogastric feeding. This is nasogastric feeding. How we insert? This is the nasogastric tube. So you take the tube, first point at nostril, then earlobe, then lower part of sternum. Just this is the length. This is the length you mark. This is the end in your hand. So this touches the earlobule and this touches the lower part of sternum. So your tube should be this much inside. This the point you put the tape. How you measure the length of nasogastric tube? From nostril to earlobule to the lower part of sternum. Got it? Now see. See this picture. See this picture. This is the feeding practice between 32 to 34 weeks. Where some coordination of sucking and swallowing. You put the palladi, suthi in front of the mouth and you can see how much feed child is taking. When you are giving na, sometimes child keep few milk out also. So yeah, this is feeding under observation. You can know how child is taking and how much child is spitting out. Proper coordination is not there. So you can try this. Some ml child will take this. But after 34 week, when you are sure, now everything is child taking inside. Everything child is taking inside. No spitting is there. Then you put the child on breastfeed. So remember this table. Less than 28 week, IV fluid. 28 to 31 weeks, Orogastric or nasogastric. 32 to 34, Suthi feed, spoon feed, Palladi feed, whatever you say. And after 34 week, breastfeeding. Surprise, we have two questions in UPSC exam. Read this question. On such, this is simple table of feeding, which we have discussed in our session. A newborn delivered at 32 weeks started on spoon feeding after birth. Yes, 32, 34 week, we can give spoon feeding, but the baby is demonstrated some spilling and coughing. What it indicate? Sucking, swallowing, and respiration coordination not established. So what is the next treatment? Now it's very simple. Very simple. Child is not taking the spoon feed. Then what you will do? Put the child on orogastric and nasogastric tube feeding. Clear, na? Clear. 32 week. Yes. Agree. From 32 to 34 week, choice of feeding is spoon feeding. But child is spilling, coughing. It means it takes few more days for sucking, swallowing, and respiratory coordination. Why you want to take risk? Put the child on orogastric or nasogastric feed. Clear? Now answer this question. Yes, I want answer from your side. Jeet, Lovely, Shoaib, Shyam, Swati, Marvel, Kustub Mishra, what you answer in this? What answer you put in this? No afraid, na? You have put the answer, no problem. Nobody will change. Okay. Child speak bisyllabus. Ma, ma, ba, ba. This achieve at 9 months. If you remember this milestone, na, this 9 months. So this is out. This is out. This is out. We left with 10 months only. He able to sit without support. Yes, child is able to sit without support at 8 months. Look at the source of sound diagonally. He turn the face. Look at the source of the sound. It comes at again 9 months. So whatever child is more than 9 months. It's not less than 9 months. It's more than 9 months. So our answer is 10 months. Our answer is 10 months. So this was the question in exam. Read it. What answer you have put it? What answer you have put this? What are the reversible cause of electromechanical dissociation in pulseless electrical activity? Pulseless VT. Pulseless electrical activity. What are the reversible cause? If you know nothing, pericardial tamponade is a reversible cause. Definitely. We can drain the pericardial fluid. And hypokalemia is a reversible cause. You can give the potassium and things may be repeat. So if you have no knowledge, you can say yes, first and fourth are reversible. So whatever the answer, I will choose first and fourth. Now second and third, I have a doubt. This is the PALS protocol. PALS protocol table. Reversible causes of pulseless VT. Reversible. Hypovolemia, hypoxemia, acidosis, hypoglycemia, hypo and hyperkalemia. Hypothermia is a reversible cause. Hypothermia is a reversible cause. They have not mentioned in their tablet, in their table, hyperthermia. Yes, tamponade is a reversible cause. Thrombosis is a reversible cause, but not hyperthermia. It's PALS guideline. They have not mentioned hyperthermia is a reversible cause. So yes, hyperthermia is not. Pulmonary thromboembolism is a reversible cause. So we have a choice 1, 2 and 4. 1, 2 and 4. Answer is D. Answer is B. So I hope this little difficult question, because it takes some time, because everybody think hyperthermia we can cool the baby by any maneuver, drugs or by ice or covered in the wet blankets. Hyperthermia can be prevented, but it is not given in PALS guidelines. These are the reversible causes. Hyperthermia is not there. Rest all are in these causes. So if you know this table na, then you can very well out this hyperthermia. Otherwise, I consider it's a difficult question. Yes, I agree. Now, this is again a simple question. What answer you have put? I am waiting for your reply. A 3-day-old newborn present with jaundice since birth. Pallor, hepatosplenomegaly, cephalohematoma. So what pointer towards pathological jaundice? Pathological jaundice. So what is pathological jaundice? Jaundice appear within 24 hours. Jaundice persist for more than 2 weeks. Bilirubin level more than 15 and direct bilirubin more than 2. Now come to the question again. If any one of them out of these 4 is there, jaundice is known as pathological jaundice. See here. See. Pallor, hepatosplenomegaly, cephalohematoma, jaundice present since birth. Jaundice appear within 24 hours. It's a pathological jaundice. But here, jaundice present since birth means appear within 24 hours. It's pathological, because physiological jaundice always appear after 30 hours. If jaundice appear at birth, first day, within 24 hours, it is always a pathological jaundice. It is always a pathological jaundice. Which of the following tools are used for developmental screening? Again, I will say it's a difficult question. Yes, even I need to search from the book. Yes, which one we choose. Yes, generally we use Danvers too, in which milestones are categorized as gross motor, fine motor, linguistic and social. Definitely age and stage questionnaire. A particular age, a child do a particular activity. Parental evaluation of developmental status. This is also PEDS score. PEDS score. So these 3 are 100% right. Used in the developmental screening. Yes, sometime educator also not sure once in a while. So yes, from my side, I go answer with 1, 2 and 3. If any differences, put in the comment box. Yes, we all are learning. I am ready to accept my mistake. If I am doing this paper, I put answer 1, 2 and 3. Belay is mainly used for toddler developments. It's not used from the beginning, developmental screening. Okay, but these all used from 6 months onward, but this mainly used in the toddlers. So generally, if I need to choose answer, best 3, I would put 1, 2 and 3. This is again a very good typical UPSC developmental questions. Yes, come on, answer. A 2-year-old child, if you want to do this question by exclusion, it's very easy. Stating his name when asked. This milestone appear at 3 years of age. Child can able to tell age and name at 3 years. 3 years. They are asking about 2 years. So 4 is out. When 4 is out, answer is 1, 2, 3. Hold on, hold on, hold on. Vocabulary of 50 to 100 words. Yes, a 2-year-old child have vocabulary of more than 50 words. So A is right. Use pronouns. A 2-year-old child can use I, we, you very frequently. 2-year milestone. It is again important. Occasional repeating of word. Yes, a child can repeat words at 2 years of age. Again, this is the important milestone. But name, child can able to tell at 3 years. So what we learn here, vocabulary of more than 50 word at 2 years. Child can able to tell 2 words vocabulary at 1 year. 10 words at 18 months. More than 15 words, more than 50 words at 2 years. Pronouns at 2 years. Repeat word at 2 years. But name and age at 3 years. So it's very simple other way around. 1, 2 and 3. Now, which of the following statement is correct in context with human breast milk? Concentration of lactose 5 gram not. It is 6.5 to 7 gram. Protein content is higher than that of animal milk. No. Animal milk contain protein 3 to 3.3. Human milk contain protein 0.9 to 1.1. But it is a good quality protein. But overall protein is less in human breast milk. Human milk does not contain taurine and cysteine. It contain, this is the particular, this 2 amino acid is good for brain development. So its main point of breast milk that it contain taurine and cysteine, but they are asking not contain. So A is not correct, B is not correct, C is not correct. Human milk contain omega 2 and omega 6. Yes, human milk contain unsaturated fatty acid, which is good for brain development. Cow's milk contain saturated fatty acid, but polyunsaturated fatty acid. Human milk. Last 3 years, every year you find 2 questions on breast milk, 2 questions on breast milk, and we have discussed all these things in our classes about breast milk. Yes, human breast milk contain taurine and cysteine. It is contain 6.5 to 7 gram lactose. Protein content is less in human milk as compared to cow milk, but that is a good quality protein, easily absorbable, easily digestible. Again, simplest, if mother is HIV positive and baby born, what care we give to the baby? If mother is taking retroviral therapy in pregnancy, chance baby is positive is just less than 3%. But we come to declare baby negative when we get 2 negative sample, in which first we do at 6 weeks of age till we considered all baby as a positive, and we start nevirapine to the baby. Nevirapine to the baby, 10 milligram nevirapine to the baby, 1 ml drop we give till 6 weeks of age. When we do the DNA PCR, HIV DNA PCR, and if it's come negative, we stop the nevirapine. So which drug we give to the baby who born to HIV positive mother? Nevirapine. It is again a simplest of question we did so many times. Now, what is the diagnosis of autism spectrum disorder primarily based on? Primarily is only clinical criteria. Child has poor eye control, shy, stereotypic behavior, clumsiness, repeated behavior, inability to speak proper sentence, no social interaction. These are the clinical criteria. Once primarily based on, they are asking primarily based on. First, the clinical criteria is only. Then we move to genetic study and MRI to put into whether it's a some syndrome or plain autistic disorder. So primarily based on clinical criteria only. Any confusion, Piyush? NKN, any confusion? Autistic spectrum disorder primarily based on clinical criteria only. Answer this. Vitamin C. Which of the following regard to vitamin C? Answer. It is heat stable. No, it is not heat stable. Destroy by boiling. So not heat stable. Normal platelets are poor in ascorbate. No, platelet have good number of vitamin C. First and second is not correct. Infant feed exclusively on boiled milk are vitamin C deficient. 4 is right. 4 is right. Now, if you don't know anything about 3, you are sure first is not correct and fourth is right. So fourth is either here or either here. First is not correct. So C is not the answer. Answer would be D. Yes, perifollicular hyperkeratosis is the classical skin finding of scurvy. Perifollicular hyperkeratosis. Crow shaped hair, brittle hair. Yes, this is a feature of scurvy. Perifollicular hyperkeratosis is a skin manifestation of dermatological manifestation of scurvy. Perifollicular hyperkeratosis, perifollicular hemorrhages, and perifollicular hyperkeratosis. This is the classical of scurvy. So yes, 3 and 4 is correct. 3 and 4 is correct. Answer this question. Elderly word comes. It's not a pediatrics question. Yes, our limitation is 1 hour. There are typical 25 question in pediatrics which we have discussed, and another 10 and 10 to 20 mix with medicine. You can put them in pediatric also, you put them in medicine also. This is one of them. Alcoholic male, alcoholic will come na, you think it's a thiamine. Eat a diet of maize, where maize is the staple food. There is a deficiency of niacin. Presented with complaint of diarrhea, sunburn, dermatitis, and delirium. DDD, diarrhea, dermatitis, dementia, delirium. It is pellagra. It is pellagra. This is pellagra and need niacin therapy. Pellagra and need niacin therapy. That vitamins we discuss in our special class for UPSC, where we cover this extra vitamins. This is there. This is there. This is pellagra and niacin therapy. So yeah, it's an effort from my side to cover questions asked in UPSC. Sometimes we give the exam, but we should know what are the correct answer. Suppose some who are planning to give UPSC next year. So now after seeing this class, you have idea that we need to read poisoning. We need to read developmental milestone. We need to read neonatology, mainly breastfeeding portion. So these are the few PSM program, RBSK. These programs, there are a lot of questions. No systemic pediatrics asked in UPSC. By looking this video, you can see these are the prototype of questions. We discussed 21 paper also, 20 paper also. This is 2022 paper UPSC. So keep reading. Let's crack it. If you like this, share with others. Yes, myself, Dr. Sanjay Khatri. Thank you. Bye-bye. God bless you all. God bless you all. Thank you.